for the next session is going to be presented by Dr. Mary Strauss from Wisconsin. She was the leader, along with Anita Stephen from UK, co-leading the respiratory pulmonary work group during our standard of care effort. And so she basically wrote the section on the consensus statement. And she's going to tell us all about respiratory care for the nuclear ocean.
Thank you. Thank you very much to Dr. Wang and Stephanie for inviting me to be here today to present to you. I can't take full credit for it. I had 12 of my good friends, other PD pulmonologists from around the world, helping me write that section. So these are, I'm very involved with SMA research. I'm also the chair of the FSMA Advisory Council currently. So these are the things that we're going to cover today. Understanding the respiratory pathophysiology of SMA, understanding the standard of care that's out there and available, and developing a strategy for managing kids with respiratory complications. So we've already talked about this. Dr. Lang covered this quite extensively. Dr. Lang talked about kids with SMA dying very early, and they typically die of respiratory complications. That really is the cause of death for all type 1s, most type 2s. So respiratory function in SMA, they have very weak intercostal muscles. Essentially the intercostal muscles, the muscles between the ribs, don't work. They're all diaphragm breathers, they're dependent on their diaphragm, and you can see that they're all belly breathers. In the first year of life, the chest wall is very soft and flexible. So the chest wall changes that we see over time, and they're more common in type 1s, also very common in type 2s, especially if they don't receive any sort of respiratory support, is that they develop this bell-shaped chest. It looks like someone grabbed them at the bottom of the rib cage and pulled it straight down, which is essentially what's happening. There's no intercostal muscle to counteract the force of the diaphragm, so the rib cage just ends up looking pulled down. I want to talk about a case of a child with SMA type 1, which is classic. This is just a very typical presentation of what happens to these kids. This is a 7-pound, 14-ounce product, a child with uncomplicated pregnancy. At a month of age, her family noted that she had decreased head movement and wasn't moving her extremities like she should be. At 2 months of age, she's diagnosed with gene mutation testing by a neurologist in Milwaukee. At 2.5 months of age, she got her first cold. Colds are devastating for this population. She had a runny nose and developed difficulty breathing very quickly. Her parents took her to the local emergency room, but on the way she arrested, had respiratory arrest. When they arrived at the emergency department, they resuscitated her, placed her on non-invasive ventilation, and then transported her to the closest tertiary care center, which was Milwaukee Children's Hospital. During her hospitalization there, they placed a gastrostomy tube because she wasn't eating well. They also treated her with a variety of nebulized medications, including albuterol, almazine or DNase, tobramycin for pseudomonas and secretions, and also ranitidine or Zantac to try to limit the reflux. She was there for a month. She was not intubated. She was discharged at home with supplemental oxygen to use as needed. Also sent home with a pulse oximeter, a suction machine to help with clear secretions, and a toposis machine, which we're going to talk about more, and we'll demo this afternoon in our workshop. And the plan was to do a sleep study in a month, so she did not go home with any sort of respiratory support other than supplemental oxygen as needed. So 2 weeks later, so she did well for 2 weeks, and then about 2 weeks later she started having oxygen desaturations during sleep. Her parents started supplemental oxygen, first set of 1/4 of a liter. She was having intermittent episodes of low heart rates to the 80s. Normal heart rate for a 4-month-old is 120, 150. She was discharged and advised to continue memory clearance, so they didn't do any intervention, they just did an assessment with her. Her oxygen desaturations continued to progress to where she was needing 1 liter of oxygen, not only at night, but also during the day, and was vomiting frequently. At this point in time, the family contacted me, had heard of my work with SMA respiratory care, and I advised them to come to the emergency room immediately. We hospitalized her. Her serum bicarbonate was 31. We did not do blood gas. She was only 4 months, and these kids are very difficult to draw blood on. What we did for her is we put her on BiPAP immediately. She actually came to my clinic. We put her on BiPAP in the clinic and with supplemental oxygen transported her to our intensive care unit. We did aggressive airway clearance with her every 2 hours. We stopped all the nebulized medications. Within 2 days, she weaned off the supplemental oxygen, but continued on BiPAP full time. Again, continued the airway clearance. We decreased it to every 4 hours at that point. By 3 days of age, or 3 days later, after hospitalization, she was tolerating time off BiPAP even there. But we were continuing to use it at night, which was her new baseline. By hospital day 6, we were able to discharge her home with BiPAP or nasal mask to use during sleep, including naps. We provided palm cups for airway clearance. We gave them a written protocol for managing her secretions, and we scheduled her to return for a laparoscopic disinfection. She only had a gastrostomy tube at that point. So this is pretty classic, a picture of progressive respiratory failure. This is very typical of these kids with SMA, especially type 1. Type 2s can do it, but it's a much slower course. And viral respiratory infections just accelerate that pathway of respiratory failure. So the results of respiratory muscle weakness in SMA is that they have difficulty coughing. It's very hard for them to cough on secretions, especially in viral respiratory infections when you have not only a lot of secretions from the nose, but also from the lungs. There are risks for hypoventilation during sleep. All kids with SMA type 1, I would argue, will go into progressive respiratory failure. They all develop hypoventilation at some point. Type 2s are at risk. They don't all need respiratory support at night, but many do. And type 3s are a different category. Those patients actually can just develop obstructive sleep apnea and may have hypoventilation during sleep, even when they're ambulatory. The youngest kids develop chest wall lung underdevelopment. With that bell-shaped chest, those lungs do not develop well. And they also have recurrent infections that exacerbate muscle weakness. Whenever you get a viral respiratory infection, you get weaker. Whether you have neuromuscular weakness or you're normal, you don't have any neuromuscular weakness. During viral illnesses, everyone is weaker. So this is a table that we created for the standard of care documents, just going through the natural history of SMA from pulmonary considerations. They typically have normal breathing at birth. You assess through physical exam. They will progress, the type 1s will progress to develop bulbar muscle weakness in addition to respiratory muscle weakness. You can evaluate using the pulmonary function in older kids, 5 and 45 and up. You start airway clearance with cough assist as an intervention. As they progress, if you don't do an intervention, they can develop sleep disordered breathing, ineffective cough, reduced peak cough flows, which is a technique where you can actually measure peak cough flow. Essentially, it's coughing into a peak flow meter. And we'll talk a little bit about that when I talk about cough assist. We can do chest X-rays to evaluate for atelectasis, chest wall changes in sleep study. If there's a question about whether they're hypoventilating. It will then progress, sleep disordered breathing will progress to not only REM sleep, but non-REM sleep as well. With swallowing dysfunction can also develop, and that places an increased risk for chest infections, which will exacerbate the sleep disordered breathing that can occur. This will progress to daytime ventilatory failure, as we saw in the example. Patients may need continuous non-invasive ventilation. I will talk a little bit later about this, but there are so many things that fascinate me about this disorder from a respiratory perspective. I've learned a lot in my time providing care for children with SMA, and I continue to learn a lot. But what I found, there's a really cool study where they looked at doing non-invasive ventilation, and it didn't matter what time of day you did it. So they looked at patients who received non-invasive ventilation during the day and patients who received it at night. Both populations improved with decreased CO2 levels.